Welcome to this webinar. I'm really excited to be here. I'm pleased to welcome Dr. Hammerstedt, who I had the pleasure of working with when we were both residents at Harvard Medical School's Beth Israel Deaconess Medical Center in our receptive fields. Dr. Hammerstedt is board certified in emergency medicine with over 18 years of clinical experience. As a proudly Harvard-trained specialist, she works mostly night shifts. She worked one last night, being present to care for those who present to the emergency department on sometimes the worst nights of their lives: heart attacks, car accidents, strokes, bad infections, sick children, mental health emergencies, and of course, the worried well. She is proud to be able to be calm and empathic while saving lives and reassuring the ill and injured, and to be able to make an impact on those who need it at that time. And while the other parts of her career whole list is focused on prevention and reversal of disease, she strongly believes that emergency medicine represents the best of what modern Western medicine can offer for acute care. Through the years, she's held various positions of leadership, including president of the state chapter of American College of Emergency Physicians, executive director of an international nonprofit organization, medical director of a regional trauma center, emergency medicine clerkship director, member of the board of directors of a multi-million-dollar emergency medicine company, and more. And as an expert in emergency medicine, she is available for consultation and as an expert witness and case reviewer for attorneys. Her days are spent in Idaho, skiing and rafting and playing outside with her two little crazy boys, two furry chocolate dog children, and a very entertaining husband. So take it away, Dr. Hammerstedt.
Yeah, you made me sound like I know what I'm talking about. I like it. Yes, the scrubs are not for show today. I am night shift. I am a nocturnist. And so we'll talk about that a lot kind of as we go through the presentation. This part of emergency medicine is very unique in terms of some of the issues that we come across. So I just wanted to say first off, thank you, Dr. Fogelman, for having me. It's been great to reconnect after all these years. I won't redate us for when residency was, but so who's here today? Plaintiff and defense lawyers. Why am I here today? So I am passionate about education, medical students, residents, mid-levels, EMS, other specialists. We often think in emergency medicine that we sometimes know the other specialist emergencies better than they do because this is all we do. And in other countries, I actually helped start emergency medicine as a specialty in East Africa and Uganda and still work there to these days. I'm honored to have been invited here again to kind of extend my love of emergency medicine education to you. I've noticed doing some expert work with firms that I had an expectation of what you have already learned along the road about medicine and all the system issues around it, pharma administration, insurance, all that stuff. But I've learned that knowledge is all over the board, and I shouldn't be surprised because I think I know a lot about the law because I binge Law and Order. But it turns out that's probably a bad way to learn it, just like Grey's Anatomy is in terms of reality. So I figured this is an opportunity. You'll be a better advocate for your clients, both plaintiffs and doctors. And if you get the nuts and bolts of it already, then your patients have a lawyer who understands that climate better. And the doctors have a lawyer who understand the chaos that is their work and intricacy that it takes to be an expert in this field. So first off, what are pitfalls? Like when I'm talking about landslides, we're talking about the common situations encountered in a patient management situation that may result in the clinician being misled or rendered unaware of the unique knowledge or unusual presentations. And so the way that I'm going to talk about this through here is what are the major things with trauma, stroke, and sepsis that are part of litigation? And then what are the system and clinical situations that can lead to these becoming cases? And I think physicians are increasingly being viewed as one element in more of a complex system. And I do want to bring that up today in terms of what system-based efficiencies are well, and then just give you some really good overview on kind of what these clinical pearls are, that if you understand better, you'll be able to screen your cases better and then come to people like me for what kind of those upper details are. So trying to move the slide along here. Okay, so I'm going to set the scene for you a little bit. Medical systems are very complex, and you know this. The adverse events that occur within them are usually due to a confluence of like very many complex factors. Who's on staff, which hospital you're in, what your county is like, what the funding is like, who's coming in and out, who's responsible for which part of the patient, which decisions, communication, what the front and back door looks like, how many inpatients are boarding there is a really big deal right now. And kind of what is emergency medicine is like an undifferentiated surprise of like what comes through your door at any moment. And also just like the idea that most emergency physicians never own or control their staffing, equipment, resources, and that's usually a hospital administration task, and we can kind of only advise on that. A typical 3 a.m. may or may not have happened to me hypothetically several hours ago. A trauma arrival and a code critical arrive by EMS within 10 minutes of each other. I'm the only doctor. My nurses are understaffed by the hospital. My psychiatric social worker left at midnight. A third of my emergency beds are full of inpatients boarding because there isn't enough staff upstairs. And I have 7 in the waiting room, and I have a psychiatric patient swearing and screaming while being restrained by security, and a toddler with a fever next door. So that's kind of what this environment looks like for me all the time. I'm going to get into trauma. Again, the general pattern of this is going to be, what are the main like 3-ish things that we see that are being litigated? And then what is a clinical scenario, and what are kind of basic tips that you can know about what you should be looking for, what you can be guiding your clients around, and what some of those adverse events may be coming from. Trauma is not quite as straightforward as stroke and sepsis are going to be, because I do want to explain a little bit of theories and of error in medicine using trauma as an example, because it's very complicated. So I guess the first couple of things in terms of the main issues in trauma, many trauma centers will have leveling of traumas. So that means like, how sick is someone going to be? The state usually sets those with EMS and emergency medicine and some sort of political committees. They can help alert staff, but they can also anchor some bias for the staff about who's sick or who's not. Like if you came in as a level 1 priority trauma, or you walked in the front door. Much of major trauma occurs during off hours, late evenings, early mornings. This is when people are generally making their bad decisions for themselves and causing these problems for themselves or others. And that it requires optimal performance even under these like very challenging circumstances. So does your place have 24/7 coverage of the services that may require expanding the pool of personnel to those with more limited experience? That brings us to sort of what can stay and what can go in trauma. Like I work in a hospital system of 5 hospitals. We're a regional trauma center for most of our state and in the surrounding 3 states, versus a critical access center that they run an hour away. These are very different, and it feels very different in terms of what you can provide in those different settings. There is also that kind of fast moving kind of golden hour of trauma that you might hear about, which is things need to happen fast. And if you're going to save someone's life, it needs to happen in that first hour. And all I can say about that really is that fast is good until it's not. Slow can be safe, but unfortunately in trauma, you do often have to make life-saving and threatening decisions with limited information and in seconds to minutes. That includes procedures that may be uncommon for people to have to do in a regular setting. That may be using staff that doesn't have the training to know how to do those things, and on a very kind of all hands on deck situation. So I won't get into everything I wanted to on the slide because Dr. Amy told me that I shouldn't, but I do just want to point out that especially in trauma, this Swiss cheese idea of like how latent and internal errors can affect and outcome is really important, because in most places, especially at non-trauma centers, most of these injuries are going to be kind of low risk, low impact, low mechanism. So if the system around that physician sucks and the staff doesn't have a lot of trauma experience, most people are probably going to be fine. And then in a setting where it's a very high acuity patient, a certain subset of them are going to die no matter what you do, but a certain subset of them are going to need that, like every single hole in that system to not line up for things to go okay. And so, what can we do? Can we work on our side to like train every person who works in every ED to provide like state of the world trauma care? Like, it's not really possible. Even ATLS is very limited. It's a team sport. And so I think being fastidious and constantly reassessing and working with your team to practice and simulate is another way. But some of these things are really kind of latent error management in terms of, do we have the right consultants? Can we transfer someone? Do you have the right staff? Do you have the availability of the imaging that you wish that you had? And so now that I'm done tattling on the healthcare system, let's do a trauma scenario. So trauma, it's 3 a.m. I set the scene for you already. Trauma patient arrives 3 a.m. Came in with only a 2-minute warning from EMS. So where were you in that department? You're off somewhere else dealing with all these other things. He's a young male. They almost always are. No one knows his name. He's got a penetrating wound to his right chest that EMS told you. He's sweaty. He's like swinging at everybody. He's confused. He's got a low blood pressure, low oxygen saturation. And once you get him onto the gurney and undressed, you see that he also has a penetrating wound in his abdomen as well. So the most common landmines to adverse events in trauma care are airway management, detection of hemorrhagic shock, which we'll talk about what that means, failure to kind of look at the abdomen, stabilization of pelvis fractures, and procedural adverse events. I kind of already talked about those procedural events and why those are really complicated, fast decisions, and high risk procedures. But we'll review the clinical aspects of the other 4 here to show what might be leading to those top 3 trauma litigation types. So the first one, airway management. So there are a lot of people who need to have their airway controlled, as we say in medicine. So that is sedating, paralyzing, and putting a tube into their lungs and putting them onto a ventilator. So it could be that their vital signs are off, they're not ventilating or perfusing very well, they're too agitated or confused to be able to contribute to getting the data and the life-saving care that they need. That's very, very common. Injuries to head that are causing them to not be able to breathe on their own. But lots of things can go wrong. So there's a continuum from pre-hospital, so EMS, to the emergency department, to ICU, and to maybe the OR. So the biggest thing is, like, when is the right time to do this? And is someone too high of a risk to not do it right now, or too high a risk to do it right now? If you think they might need it in the next 10 minutes, really preparing for best case scenario ahead of time is a very like mentally and emotionally complicated task. So the short story for the lawyers here, that with no clinical medical experience, is this a very fast moving decision. It's high stress, big skill, lots of things can go wrong. And I think most of us just always expect the worst is going to happen and try to have our backup options around that we know how to use and we're the most comfortable with. And this could be, a 4-hour emergency medicine lecture to my residents, but I'll leave it at that for you guys for right now. So what does hemorrhagic shock mean? So shock means usually low blood pressure, and so bad blood flow to the brain and to other organs. And that can be from lots of different causes. But in trauma, it's usually from bleeding. It can be from other things, but usually from bleeding. So not all bleeding goes out though, right? So we always think about like bleeding is that you're going to be like bleeding out of your body somewhere in trauma, and it's gonna be very obvious. But people can bleed catastrophically into a few kind of boxes, and I'll talk about boxes a lot here, a few boxes in the body. So your head, your chest, your abdomen, your pelvis, your thigh are kind of like the main places where you can bleed out into yourself. bleed into yourself where you can't see it from the outside. And so it's a lot harder to recognize quickly with a lot of without a lot of expertise than when the medics come in and say there was like a few liters of blood on the scene. So this remains one of the more common and lethal pitfalls or landmine that we can see. So you would think it'd be easy. Lost blood from the vessels means the blood pressure is low, but unfortunately, normal blood pressure does not always mean that they're not bleeding and unstable. So it would be like a hidden shock, so to speak. It's developing, but we haven't yet seen that. And we see this in sepsis a lot too, which I'll get into. So a significant amount of your blood volume can be lost before your blood pressure changes, especially if you're a young, healthy person. And that's from a lot of hormonal things, stress things, fluid shifts, all those things, again, that I won't really get into. But the kind of the verbiage in emergency medicine is that like the talking patient can still be in hemorrhagic shock that we haven't yet identified. So we really need to like pay attention to the very old and the very young. They may have different blood pressure kind of parameters from that. So I think over the last 10 years, we've gotten a lot more aggressive and a lot better at just transfusing for high heart rates, assuming the blood pressure is going to go down next, and transfusing sometimes just because of what we know happened to them. So that is kind of our hemorrhagic shock. So this one will be pretty quick. This is another box, the black box of the abdomen. So from your diaphragm, and I'm pointing at mine, down to your pelvis is sort of what we call the black box of the abdomen. So lots of things can happen in there. You can see from the CT scan, even if you don't know how to read CT scans, there's a lot going on in there, right? Like the chest is easier. It's like you got lungs, you got blood vessels, you have your aorta going through there, and we can fix those things a lot quicker and faster when recognized than we can in the abdomen. So, a lot of the problem with this is accurate history. So, I mean, I can tell you even from a couple of traumas and a couple of medical emergencies that I had overnight that the information that I got from EMS who like scooped this patient and ran in was not the full story, right? And it can't be, because their job is to like just get them to us. And so the history, when it's inaccurate, you have to look broader than that. We talk a lot about blunt and penetrating trauma. If you think about car accident, that's blunt trauma. You think about falling off the roof, that's like blunt trauma. Penetrating is usually impalements, gunshot wounds, knife wounds. But did you miss that someone was blunt trauma but actually had a penetrating injury from that? And if you're not thinking about that, you can that can really drastically change the type of injuries that could have been sustained. Many of these people need imaging, but some also can be too unstable to go to what we call the other black box, which is the radiology department, where you never want to send an unstable patient because they just do not have what is they're equipped to do, even with your nurses and you, to continue a resuscitation. So then you're stuck with like, you need to look at this black box of the abdomen pelvis, but can you go to CT? Do you have a surgeon who can just take him to the OR? Is that putting him more at risk without a diagnosis? Do you continue resuscitating that person until you're able to get that information of the imaging, but with no diagnosis? So these are all a lot of clinical scenarios that can occur and do occur commonly and can cause a delay in diagnosis. Whether that was a delay that was needed to save the person's life or not is like, you just sometimes don't know ahead of time. Many of these injuries to these solid organs, like your liver or your spleen or those kind of things, are generally no longer surgically treated, but they can bleed a lot and lead into that hemorrhagic shock if not identified and transfused. And so leading us back to our last slide. This is the last one for trauma, and then stroke and sepsis are faster and simpler in a way. So I know that you aren't doctors, but even my 9-year-old who was helping me make this presentation knew there was something not right with this picture. So this is obvious, and this is a shear pelvic fracture. You can see that this whole side of the pelvis was, basically sheared off of that side. There are a lot of blood vessels that sit right around in there that are not in this picture. And so makes it high risk for bleeding in to yourself, but they aren't all this easy, especially if only as x-ray is done. So most issues with the adverse events to pelvic fractures and the bleeding into them that are so dangerous is delayed recognition or delayed understanding of the severity of it, or incorrect pursuit of treatment. So we talked about these boxes into bleeding that will cause death, and pelvis is one of those, especially in these older people, which most of these shear injuries that are this bad are going to be high-speed car accidents, high-speed falls, those kind of things. And those can be younger people. And again, these are easier to identify. But imagine if you just had like one of these little fractures there, you could still hit a bad artery and not really see on x-ray exactly what that looked like, and they could be easier missed. And those are the grandmas that fell down and have these that we wouldn't necessarily recognize. And grandmas and grandpas are definitely all sorts of higher risk for hemorrhage issues. They take these blood thinning medicines, and just their hemodynamics and their ability to compensate their vital signs for lots of other reasons. So x-ray is a helpful kind of quick look, and we often do that in a pelvic in the trauma bay to just see exactly what we're seeing. But the CT scan, the computed tomography scan, is a much more robust ability, especially if you can shoot contrast in there. With contrast just basically is a dye that like lights up the blood vessels so you can see where it's actually bleeding from. And that is what's going to help that kind of pursuit of treatment option, which is can a radiologist do a procedure to see a blood vessel that's bleeding and directly stop it? Or does the orthopedist need to like pull that whole side of that pelvis back down and pin it in so that the volume of the box that they could bleed into would be less? Does that make sense? And so depending on where you are and what hospital you're in, if I'm in my trauma center, super easy. If I am out in the critical access center, we're an hour and a half away to get to an orthopedist, don't have a general surgeon on staff, may not be able to do a CT with contrast. So what if neither are available? So then you're talking about transport issues and all that. There's a lot of talk I've seen in some of the cases I reviewed about whether a pelvic binder would have made a decision. That's basically using a special contraption that looks like a corset that goes around kind of your lower, I'm like trying to show you on me, like you're going to be able to see it, but down kind of around your hip bones and your butt to like kind of decrease the volume of that pelvis that you could bleed into. Would be helpful or not. It is helpful in some fractures for a short period of time, like a transport, but it's not it's certainly not an end all to all pelvic fractures. It won't really help. So moving on to stroke. I do love talking about stroke because I do think that there's a lot of misconceptions about all strokes being the same. The majority of malpractice lawsuits related to the emergency management of stroke usually allege a failure to diagnose. So imaging or a physician kind of miss, or a failure to treat with clot busting medicines, TPA we'll talk about, or with going in and pulling a clot out, which we'll also talk about. So clinical stroke scenario here is that code critical that came in just before the trauma in our 3 a.m. scenario. At first assessment, the triage nurse, because you're busy with this trauma, putting in chest tubes and intubating, all this stuff, is worried about a stroke. It's a middle-aged woman with slurred speech that family thinks maybe came on pretty quickly. Family's not there. EMS says, they think maybe they noticed in the last 3 hours, but they're not entirely sure. Like maybe they didn't really talk to grandma for a while, So let's first talk about why 2 different strokes. There's an anterior circulation. This will make sense in a moment. There's ones that happen up here that cause certain, usually pretty obvious symptoms, and there's ones that happen in the back. So we're going to talk about why the front ones, these anterior circulation ones, is like the classic, like your face is droopy and you've got slurred speech, or you're kind of like word salad, like nobody can really understand like what you're trying to say, but arm and leg is in weak, right? So those, most people can classify. The public and EMS know how to screen for that. It's usually caused by a clot that gets lodged in the blood vessel up here. Like maybe you were building plaque up and the plaque just sort of like just suddenly blew up and got stuck, or something came from somewhere else and got stuck. It gets lodged in that blood vessel, and it gets lodged big enough that the brain tissue that is trying to bring nutrition and blood to dies, just like when someone has a massive clot in the coronary arteries and heart tissue dies, right? Like a heart attack. So where the clot is and where that brain tissue is definitely determines that severity in the symptoms. So mostly these anterior clots, these front clots or side clots, are pretty apparent, but it can be challenging in some. And this is why I want to talk about this in particular under the failure to diagnose section. So mimics, there are some pretty common stroke mimics, that meaning like they come in, EMS called in and they're saying, we have a brain attack or we have a stroke coming. That's their assessment based on their level of training, which is what they're supposed to do. When they get there, things start to get a little bit confusing. Maybe the person's really young, maybe something about their history is weird, something about their exam isn't quite right. You have a very short amount of time to be able to decide about how you want to treat this and how you want to image it. And things that can confuse you can be sometimes a seizure can like be just leave you with your arm being paralyzed. Sometimes you can have complete blindness from a migraine. Sometimes you can have a whole side of your body paralyzed from a migraine. There's convergent disorder, which is a kind of semi-psychiatric condition where people's bodies really respond with real signs and symptoms that can mimic a stroke and other things. And the other night I had a lady whose blood sugar was 3 instead of 90 to 150, and she had right arm paralysis that completely got better when her blood sugar came up. There can also be, I'm sure you've heard of TIAs, which we call kind of like mini strokes, which are basically like you had an occlusion in that blood vessel, that artery, it got stuck and you had the symptoms, and then it like floated away and then your symptoms went away. So all of those are things that like if we do the wrong thing for or give the wrong medication for that clinical scenario could cause very bad downstream effects if you're giving them like a clot busting medicine and they had a complex migraine that wasn't expected. Posterior strokes are very different and they're harder, and I'll talk about that in a moment. So when we talk about imaging, I've seen in a handful of case reviews that I've been a part of for strokes and for particular posterior strokes is like they didn't get the right imaging at the right time. And I think the hardest thing for us is, again, kind of that latent system error, the Swiss cheese error that I was talking about, like CT versus CT with angiography versus MRI. Who's going to read it? Do you have it? Can you get to it? So I'm going to explain to you what these 3 things are, because I do think it's really important for you to understand this when you're scanning your cases and deciding if you need to send it to someone like me to give you more advice. So a regular head CT without contrast is generally pretty easy to get for most emergency departments in the US. Although I have seen smaller hospitals, even smaller than my critical access one in Idaho, who they have to call in someone from home to fire up the CT scanner to be able to do a CT scan, in which case you're going to run out of time pretty quick. But a non-contrast, that being said, most places can get a head CT that they just take a picture of, there's no dye, they just do it. That is very good for bleeding into the brain, so not the kind of stroke we're talking about. kind of looking at a couple of things that might be able to give you hints of whether going in to get that clot physically or giving that clot breaking up medicine is going to be the thing that is the right thing. You can also find like a big brain mass or something like that. So it's generally helpful, but is definitely not going to give you all the information you can. Most of the time, if you have a CT scanner that you can use quickly, you can get something we call a CTA, which is a CT with contrast that's put in a certain place so that it lights up all the blood vessels and the arteries in your brain, arteries specifically, so that you can see if there is a clot stuck in there and where, if it is, where it is. Some of these sites can get something else called a CT perfusion, which helps you see if the brain tissue around that clot is at risk of dying. But I can't get perfusion at some of my sites due to capacity of the CT scan. The radiologists sometimes don't want to do the angio if the onset of symptoms has been past the time that they think that doing the clot busting medicine or the retrieval of the clot could be helpful. And that is complicated. And I'll talk about that briefly in a minute. Some radiology groups and stroke centers will not even be responsible for the reading of a CT angio or a CT perfusion read, and it goes like elsewhere to radiologists somewhere else to interpret, which sets about all sorts of other issues. The biggest thing that I have seen in some of the, especially posterior stroke reviews that I've done, is that the MRI wasn't done. So the MRI is most specific to look at the brain tissue for kind of definitive diagnosis of the stroke. So the CT scan with the contrast and perfusion, if you can get it, is going to see a large clot or not see a large clot. That's when if you see a large clot, you want to go get it. We're going to talk about that in a minute. If the symptoms of a stroke are there and you don't see a big clot you can get, then you're talking about the medicine. But it's still somewhat of a guess. It's a guide. The MRI is most specific to look at that brain tissue itself. So I work in, again, as I said, 5 emergency departments. They're not the most urban or the most rural of places that I've worked. Amy and I know each other from working at Harvard. Obviously, I had all the things there. So for example, I can get an MRI in 2 of the 5 emergency departments at any hour by calling someone in from home to do that, which comes up with lots of loaded administrative things. One of the other places I can get it during the during the weekdays, during business hours. I think right now it's like 8 to 3. I don't know whose business hours those are, but they sound pretty nice. The other 2, I can't get them at all. And so MRIs are really not emergency department standard of care part of workup. And they're often relayed then to admission inpatient teams to get done the next day when they're available, or transferring someone to get that done. So I just want to be very clear about these 3 imaging techniques and like why they could be helpful or not helpful, and kind of what amount of time that people could get them done in. These are the 2 things I've seen in stroke, which are the failure to treat issues. And I'm sure you guys have heard about at least the TPA, the thrombolytic. There's another one called TNK, which we're using more frequently, at least in my shop. This is the clot busting medicine that everyone wants when they come to the emergency department because it's been out there in the media. And I'm going to just say this, that like 20 years ago, this was very well accepted in the emergency department literature and in the neurology literature to give. But it is currently very controversial because we've had many very well done studies that show that it may not be helpful. And then it may have pretty catastrophic events when it's given correctly and when it's given to a mimic. So regardless, kind of across the board. So it's very time sensitive. It's a hot button. The controversy exists over the efficacy of the treatment. The biggest thing is if you give it and too much brain tissue that you don't know is already dead can bleed. And that is like, deadly or hugely disabled where they may have recovered from their stroke without it. You don't know that ahead of time. You don't know when the symptoms started. There's lots of patient factors such as like dementia, or elevated blood pressure, things like that. And also sort of our decision making around that. Is someone getting rapidly better? Do we think it may be more of a mimic? Is there going to be a threat of litigation due to the side effects of bleeding because I gave this medicine? There's a controversy in the efficacy over it. And not to mention that many hospitals are incentivized to make sure that there's a certain speed of time that this medicine is given within the time that the patient arrived to the emergency department, which a high risk medicine like this, with we're not sure about the efficacy, is very loaded, as I'm sure your brains are all thinking the same thing. So I do think if you get 10 emergency docs in the room, you will get 10 different opinions on this. And so I think that is the problem with this medication and why it's controversial and complex. The other is this efficient access to thrombectomy. So thrombectomy is when you see on that CT scan with angiography that there is a very large clot stuck in this one part up here. They've got the facial droop. They can't talk to you. Their arm is flaccid. Like, God forbid, this is like a 50-year-old, right? And you really want to fix this. And it seems like the best thing to do is going to be to have someone go in under picture while taking pictures, the radiologist, and they can scoop it out, right? That obviously is not done by your run-of-the-mill radiologist who's usually like at home reading their images. So it has to be a interventional neuroradiologist. These large vessel occlusions, they account for approximately 30% of people with this kind of stroke that I'm talking about. And maybe only, I think the data that I looked at when I was preparing for this said that maybe only 3% of these acute anterior stroke patients received mechanical thrombectomy in 2016. So why is that? We used to think 8 hours was it was like the time, the window of which getting there could save the brain tissue. We're sometimes now kind of controversing ourselves about whether it could be 24 hours. That kind of limit of time expanding is helpful because it can get people to that kind of definitive care. Because I can tell you, even when I'm only an hour and a half away from my kind of mothership that has all this stuff, sometimes there's no EMS, sometimes the weather's bad and I can't fly anyone out. Sometimes it could take 4, 5, 6 hours for me to even get anyone out of the department. So that's very challenging for that. There is a study that shows that every 10-minute delay to this revascularization, getting that clot out, lowers a patient's disability-free lifetime by 40 days. So it's pretty big. So the question is, what are the barriers to that? I mentioned some of them. It's information, right? Does EMS know where the right place to go to get that? Should they just skip me when I'm at my rural place and drive to me at our Boise mothership because they suspect by their protocols that this is the right place to go? Is there physical access to that? I think the last data that I saw is that the US access is, I think, only 2/3 of patients with rapid access to getting thrombectomy, even in urban areas, get there. Like, so yeah, I mean, don't even get me started on the post 2020 transport and transfer issues. And then there's financial access, right? Like, so the ability of that patient to pay for that treatment with insurance and socioeconomic access issues. So this is basically showing you what this window looks like, right? So did family notice these symptoms? And then like, wait, am I really noticing symptoms? When did I see these symptoms? Did I hear about a stroke? Should I Google what a stroke is? Maybe she just has a UTI. Is grandma just confused? Is she really slurring her speech? They call EMS. EMS may not recognize that they have this possible like large vessel occlusion. They take them to the rural place, and then you can see how all this happens. And then you get to this point where the doctor is like, they finally have the patient, they finally got a good exam, they finally got the imaging, and then they're like, but the literature says I shouldn't give TPA or TNK, the clot busting medicines, after a certain period of time, or we don't really know when this patient had the symptoms start, and so I don't know if I can give this medicine or get them to thrombectomy. So that is what we're talking about. Posterior strokes seem to be hot button these days. I've been reviewing a handful of these. 20 to 25% of acute strokes are in the back part of your brain. So that's simplified, but posterior circulation. They're responsible for the brain portions that do vision, they do balance, they do kind of like knowing where I am in space, and like very main capacities like breathing, heart rate, blood pressure, sleeping. So they can be difficult to diagnose because it's not like the facial droop, can't move my arm, can't talk. This is like, I'm dizzy. So like, God help me with all my grandma who are dizzy, right? Like dizzy can mean anything. It could be nausea, vomiting. It could be like a sight disturbance that the patient really can't describe to you. It can be a balance problem. They can be very well confused with inner ear problems that you certainly don't want to be giving something like a clot busting medicine to. So very simplified, these people can be dizzy, drowsy, unable to talk, visual problems, or like having trouble swallowing even. We call them the five Ds: dizziness, drowsiness, dysarthria, diplopia, and dysphagia, for very fancy words. CT is not helpful. CT angiogram with the contrast, rarely helpful. And an MRI or an MRI with contrast is key. But again, do you have it? Can you get someone to it? I've seen cases of emergency physicians litigated against because the MRI was done. It was just done later in the hospital course. But I work in a lot of emergency departments. Again, where getting a stat MRI in the ED is quite literally impossible. And so we do just, we admit to Dr. Fogelman with the plan to get the MRI in the morning because that's what the opportunity is to get them. And really, it is the only way to really identify these. There are some very complicated clinical exams that you can do that can give you a clue to that. But this is the one that I've seen the most. I'm going to take a sip of water and let you digest the stroke for a second. So sepsis is like my thing, and I'm not going to talk about it nearly as much as I want to, but I've worked running sepsis committees for a really long time, since my Harvard days. And I do love talking about it. So what is sepsis? And these you can see on the screen these are the three main things that we see sepsis being litigated for. What is sepsis? It's a word we hear all over the place. Let's just kind of dumb it down a little bit about like what it actually is. You have an infection. For some reason, that infection has messed with your immune system enough to help it fight the infection. That's what we want your immune system to do. But also, especially when it spreads into the blood, start an immune dysregulation. So your immune system's like trying to fight the infection, but for some reason it's confused and it's getting things all inflamed and things get off, and your immune system starts kind of like leading to shock, that poor perfusion and multi-organ failure because it's not getting enough blood supply and it's being fought at. So that's not exactly correct. And neither is fighting. This is when my post-night shift is happening to me. Do your own body, right? So it's not just fighting the infection anymore. So it can be pretty easy peasy, and can be pretty easy. It can also be very, very insidious. So it's also very dynamic. So not like when you get injured or you have a stroke insult or you have a heart attack, like those are like, boom, it happened, right? This is a time frame that is tricky and different for every person, and every bacteria and every scenario and every Swiss cheese opportunity of your own body that made all of this happen. And it's very common. It's much more common than heart attacks, much more common than major trauma or stroke. I'm sure that Dr. Fogelman can also attest to this, is that like sepsis is every day. It's every day, multiple people a day. So it's arguably harder to diagnose and treat than those other ailments as well. Sepsis affects 1.7 million adults in the US per year and contributes to 250,000 deaths. It's 30 to 50% of hospitalizations that culminate in death. And unfortunately, these septic shock and sepsis related deaths have decreased very little in the last few decades, despite us doing tons of research. Like, I can't even, I mean, Amy, you probably remember all the sepsis protocols that we had when we were in residency that now we look back on and we're like, okay, that was bananas. Like, because we've done tons of research, and like our institution was kind of very like cutting edge on that at the time. And you know what? Like, we just have not made a lot of progress in terms of this disease process. So failure to recognize sepsis or to consider, failure to administer proper administration, antibiotics or treatment, and premature discharge. So your clinical scenario, 59-year-old with diabetes comes in the front door while you've got your trauma and your screaming psych patient in your full waiting room, and and your stroke patient. And she just tells EMS that she just tells the triage nurse that she just feels like a little bit weak and like maybe a little bit confused. And they find her to have a temperature of like 101 and heart rate's a little bit high. And the triage nurse says like, well, everything looks kind of from the outside okay. So she kind of gets parked in the room if you're not lucky enough to have a room. And she orders some protocol labs and some IV fluids. And by the time you get to her, she has some lab markers that are some like a little confusing. Like, they're a little bit like, most of the time they look okay, but then there's a couple of things that are a little worrisome. And she's feeling better after getting some IV fluids, but maybe her blood pressure looks a little bit off. Amy, does this sound familiar?
Yeah.
Yes. So diagnostic delays. So early detection can be really difficult in these otherwise healthy people, because that lady could be like a million different things. The fever is helpful, and not all septic patients have fevers. Some studies show that nearly 50% of patients made multiple visits to outpatient clinics or to emergency departments before recognition. That's because it's dynamic. That's because old people and babies are tricky. It means that if someone already saw the patient and diagnoses them with something, you can anchor on that in terms of a kind of cognitive bias and think that that must be what they have and miss other signs. There's also a lot of different diagnostic guidelines that have changed over the years, as I was alluding to, with all the research things that we have thought were going to be diagnostic or thought to be treatment ways that didn't necessarily pan out. So keeping up with that. And then really honestly, and my dad's a biochemist and he's constantly trying to come up with tests. And I have this conversation with him all the time. Yes, he's 82 and he's still running an active biochemistry lab. Is that there are just a lack of good diagnostic tools. So blood cultures take days. There's a blood test called a lactate, which can be elevated in other things besides sepsis. There's another thing called procalcitonin that's not really validated in my emergency department patients. There are things with vital signs that can happen with non-infection things, and only 25% of people have a fever. So, and the hemodynamic instability, that low blood pressure that's from septic shock, is late often. So we're often left with like my gestalt, like I think this person might have sepsis, plus my exam and history and an educated decision making. And all of this with a nuanced kind of changing disease state makes it challenging. So we also know as well that like overdiagnosing sepsis is also harmful, because if I'm giving you too many fluids and then you can't breathe because you have too much fluids, or I gave you inappropriate antibiotics when you didn't need them, then like antibiotics cause all sorts of problems themselves. So the other one is kind of this failure of appropriate treatment. So unlike trauma, where we talk about like the golden hour of, you know, taking care of someone and diagnosing quickly and making quick decisions, and you're going to save someone's life in that hour, we used to have a lot of pressure from insurance companies and the government to treat these people really fast with antibiotics. But it doesn't really make sense in sepsis, because the initial papers were kind of diagnosed on people who were already in shock, and often like with this, we need to be able to a little bit to delay that decision making to get the right data to observe and decide when the right time is and use the right antibiotic, because killing the bug may not be as important as stopping that inflammation and immune problem that's causing that. I won't get into lots of other things I want to, but the very last thing was premature discharge of sepsis patients. Again, this is a very dynamic situation. I'm sure Dr. Fogelman has been a lot of situations as an inpatient where someone was super sick and they were getting better and they were feeling better and they're ready for discharge. And then somehow something got delayed because they couldn't find them a rehab place or someone to take care of them at home. And then they crashed the next day and everyone's surprised because that's what sepsis does. And so dispositioning a sepsis patient out of the emergency department or out of inpatient can be one of the most consequential decisions I think that a treating clinician can make. And I think it needs to not only be determined on their condition at that time, but really, again, like who can take care of them? How reassessed have they actually been? Can they come back? Do they understand how to come back? Do they have follow-up? And right now it's not easy to get someone into an outpatient clinic. So those are my main points on my decades-long love of sepsis. So thank you. I hope that was helpful. This is my email address and my cell phone number. If you guys have questions or have anything that you want me to review, I am on LinkedIn with lots of information about me there.
So Dr. Hammerstedt, can you explain what a code critical is? You mentioned that a few times in the talk.
Yeah, so I think every hospital system, every state probably has different language for those, or maybe even every city does, depending on your state. So in our state, we have a time-sensitive emergency committee that is the legislature, plus those of us who are experts, and we sort of decide on these kind of things and then educate all of EMS about what the protocols are in our state. It's probably different everywhere, as politics are everywhere. But so, for us, a code critical means a medical patient who is critically ill for some reason, like their blood pressure is really low, or they're not breathing, or they had to be intubated on the scene, or they are actively having a heart attack or something like that, or they're febrile and confused and clearly in septic shock. Those kind of things that the EMS knows ahead of time that they're going to need all hands on deck. And when we get that call in and saying they're in 3 minutes with a code critical, and they give you a one-liner, then you can call your respiratory therapist and call in other nurses from other departments and get the blood bank ready and all those kind of things that you have a few minutes. So, and then other systems, trauma alerts are going to be different based on different criteria about what level the EMS thinks that they're going to be bringing you and what sort of resources you might need. That means I call my trauma surgeon to come if I have one. Those kind of things. And then brain attacks are what we call code strokes. And then often if there is a very clear heart attack that we call a STEMI, which is something that's going to have to go right to a cardiologist after I assess them, then they call those. And those are the main time-sensitive emergencies that EMS will call for us.
So here's a question. Have you ever consulted on a case where there was an actionable administrative system failure? It seems like there is a conflict between providers who are trying to provide the best care and the medical complex, which is more profit-driven. It doesn't seem fair that the patient bears the cost of an administrative failure, which the individual provider uses as an excuse to the adverse outcome.
I think I was following you into the last line. I have personally never seen, or I don't think heard of, but Amy has a lot more perspective on this than I do, about whether there was a system failure that was found to be at fault. I do think that nationwide that this is the biggest problem that we're facing. And the reason why I was talking about a lot of things that I have is to try to point that out as being a real problem, especially in the last several years.
Heather, can you also explain with non-physician providers in emergency rooms?
Yeah. So, I mean, I think that there is a big role for non-physician or providers. in our healthcare system. I think that they function as great physician extenders when they've had good practice, good training, good education. I think everyone just needs to understand that some of those people may have had 500 hours of online training versus 15,000 hours of a physician residency training. And so clearly what you're getting changes, and training matters. And I think it's important that that the community understands that, so that they can ask who's taking care of them and ask who else is going to be taking care of them, and that we as physicians and the hospital systems use them appropriately in a way to offload volume and see lower acuity things, and work with the physician-led team to make sure that all the holes in the T's are being crossed. I would like to think that that is the way that it's being done all over, but I think everyone in here knows that it's not.
Yeah, there are emergency rooms where physician groups are being fired and replaced by
Yes.
non-physician teams.
I've put private equity, Wall Street owned companies. Yes, yes. I'm very happy to be in a physician-owned democratic group. We contract with a great hospital system, and that's not the case everywhere. We employ some non-physician providers, mid-level providers for us, and they do a great job in the settings that they have, and they're excellent members of our team, but we're very conscious about how we use them.
Here's a question. I've had several cases where a hospitalist is involved and consults with ER. Well, they don't, so hospitalists don't consult with ER, but anyway, this is what the question says. I have had several cases where a hospitalist is involved and consults with ER and other specialties. When it is time to discharge, they all point the finger at each other when the discharge results in a poor outcome. So I think it's just, there's many different specialties that touch on the patient during their care throughout the system. So the way that it works, just to let you guys know, is that the patient first is in the emergency room. They're seen in the emergency room. The emergency room team makes the decision of whether to admit the patient to the hospital. And then when they're in the hospital, different specialties are involved. That's how it works.
Yeah, and I alluded to that at the beginning when I was saying, like, which person on that team in the emergency department is responsible for what parts of the decision can be very murky in that kind of time frame. So I think what the person the lawyer is alluding to is, like, maybe the hospitalist came down and said, I don't need to admit the patient, we'll discharge them, and then something happens, and then whose problem was it that patient was discharged and they had a bad outcome? So it is very murky. I hear you.
And there have been cases, like I remember when there was a patient, when we talk about a patient being boarded in the ED, when there's not a bed for the patient up in the inpatient system, what happens is that the patient has been deemed that they're sick enough that they need to be admitted to the hospital under the hospitalist team, but their body is in the ER. And I think who isn't responsible for that patient and who puts in orders depends on a lot of factors, including the hospital and how they do their own, how they do that. When I used to take care of patients in the hospital, we would take care of the patients down in the emergency department that were on medicine, but that was very challenging because we were physically,
you're not in your space.
We're physically, a bunch of flights away from these people, and then had to come down.
And it's the emergency nurses who are not internal medicine nurses.
Right. So there's a lot of systems errors that can occur. And I would imagine there are probably emergency rooms where the emergency room staff has to be in charge of these patients that are boarded until they are physically in the hospital. I'm not sure.
The last year and a half has been terrible all across the country for this. So it's a big issue.
How can an attorney tell when that has happened, when they're looking at the records?
I don't know if you're going to be able to tell unless someone was very, very clear in their documentation. And I'm like OCD about my own documentation for a lot of reasons, about whether that was the case, unless you were very sophisticated. I think looking at the nursing note would probably be where you would find it, because the nurse
The
Yeah.
nurse would change when they made it to the hospital floor.
But the nurse changes every 8 to 12 hours in the emergency department. So it depends on whether their notes are still getting filed as emergency department
Oh,
notes or whether they're being filed as inpatient notes. I bet they're being filed under emergency department, even though they're inpatient because it's
right,
my nurse.
right.
And
That's what I would
so,
think.
yeah, I think it would need someone like me to like dig into it and really figure it all out. And even after that, maybe even farther on is like really figuring out the names of those people and what they work on. I mean, I don't know. Some places like my main hospital, the regional referral center, has like a transfer center that they document all the phone calls back and forth. So it could be like Dr. So and so admitted this patient was going to be boarding in the emergency department, but those notes aren't going to say how long they were there, where sometimes it might be 6 hours and sometimes it might be 3 days.
All right. Thank you guys so much. Thank you, Dr. Hammerstedt, and
You're welcome.
stay tuned for the next talk in our series.
Thanks. This was fun.
Okay. Bye, everybody.